Casting live. One more spine surgery for the day. This will be a lower back pain patient. This patient's had lower back pain going into the right leg for years. And he has 3 herniated discs, L3-4, L4-5, L5-S1. We're going to fix today endoscopically with the Deuk laser disc repair procedure. I've done over 1,400 of these surgeries, and this is another one we're going to be doing today. Sir, are you awake? I'm going to give you some numbing medicine. Just lay still. So I'm going to numb the skin up where I'm going to go in and make my incision. That way we can give him some good relief. I'm going to try to do everything with 1 incision, but sometimes I have to do 2. 7 cc's injected. Are you okay? You just lay still. You're doing great. We're going to use an x-ray machine to navigate us. So you know where the problem is. The spine is too high. You need to drop the table. Yeah, you got to tell your anesthesiologist. Shot? All right, not bad. So my field of view is too small. Is that the best field of view we can do? Uh-huh. All right. Well, in that case, I do want to start a little bit lower. Shot? We need to fix that. You went too far south. Shot? All right, that's not bad, but your pedicles are off at 5. So we're trying to line the x-ray machine up with the spine so we get an accurate depiction of the anatomy here. I'm going to be using this anatomy to navigate. It's not terrible, but it is off. I think it's off on the WAG, right? Do you think so? You agree? Now the surgeries we do are all endoscopic. I think that's worse. And they're done endoscopically transforaminal on the lumbar spine, meaning we're going through a hole that's already there. Try a little more. See if that is pedicle or not, because it's kind of consistently still there. Try a little more. Shot. Actually, that is better. So you need to move your whole machine north and then wag back to where you were. So this surgery is done with a unique approach to the spine, coming from the side rather than the middle. Whenever surgeons come from the middle, which is what 99.9% of spine surgeons do, they encounter bones and ligaments, and then they have to remove them. You need to wag a little bit more, just a tiny bit more. And when you start removing bones and ligaments out of the spine, lo and behold, you get instability. That's pretty good. All right. So instability is what surgeons create by doing surgery where they're removing bones and ligaments that, in my opinion, they shouldn't be removing, because we now have the ability to fix spine issues endoscopically. And what that means, Shot, is that we are approaching the problem in the spine using a tool called the endoscope. And endoscopic surgery is something that has been done for years. Shot? Now this patient's had surgery before on his back, and it didn't work too well. We didn't do it. Someone else did it. But it looks like a kind of a microdiscectomy thing. Nice job, Jordan. Jordan, you're on fire, man. Oh, look at that. I think I'm actually a little bit too medial. Interesting. Yeah, I got to be careful because that's where the laminectomy defect is. So I'm going to go back and I'm going to come in a little bit more lateral than I am.
Do you have a laminectomy video?
I do. Why? It's called a microdiscectomy video that I have. Shot? All right. So I'm going to come in a little more lateral. Shot. 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 We're dealing with scar tissue, and honestly, we don't know what that other surgeon did over here. Is he awake and reliable?
Yes, he gave me thumbs up.
Okay, good. AP? Well, let me know if you're having too much pain, okay? Sir?
Yep, he said okay.
And let me know if you feel any pain down your leg. You might feel a shock, but I don't expect it. But if you do, tell me. All right, once again, I'm more medial than I want to be, but very close. I want to be, at this point where I'm this medial, I'd want to be on the disc, on the lateral view, which I'm not. So I need to go a little bit more lateral again, just to stay out of trouble.
Where are you feeling
Shot
that, sir?
in his back.
In the back, okay?
In the back, right?
Yes.
Shot. Yeah, I apologize. Yeah, all right. Shot. 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 Where do you feel it?
Where are you feeling that, sir?
AP?
Right where you are. That
All right, you're doing really good. I'm going to try to get you to sleep as soon as I can, okay? So I used, yeah, it looks really good. The squiggly line there over the sacrum is just the Raytec here. It's a little blue thread that's radio opaque. All right, looking good, looking good. We're in the area of his old surgery, and are you okay? Shot? Probably hitting, just hitting that S1 end plate. I need to be probably just a smidgen higher. Perfect. You all right? That looks good. So I'm inside 5-1. I'd like to try to do all three with one incision. So I'm going to make my incision. 7 millimeters, no more, no less. Just long enough to do the actual, accommodate the tube. The tube is what we do the surgery through. It's called an endoscopic tube. You doing all right? You're doing fine, sir. Thank you for being so patient with us. Uh-huh. We need to be a little further south. Oh, by the way, the last patient's already going home. That was the cervical, 4 level. Huh? One incision. That's historic. Literally, no one in the world has ever done that. I'm 100% sure of it. I'd give you my firstborn son if I'm wrong. Shot? I'm sure Arias will be listening to this someday. Where do you feel it?
Right where you're working.
All right, you're doing really good. Just hang in there, buddy. Shot. So I'm aiming for the 4-5 disc at this point. I'm trying to navigate around this other shot, this other needle that's already there. This is where he's had his surgery, by the way, 4-5, 5-1 region. And again, I don't know what that other surgeon has done. So I'm kind of hoping he didn't do anything bad down there, because if he did, I'll probably run into it. But I don't expect him to. Preoperative diagnostic imaging doesn't show you everything. Heading for that 4-5 disc. Okay, too medial. Just too medial. So I got to go more lateral. That's the problem, is all the scar tissue from his prior surgery is making it harder for me. Shot? Because where there's normally bone, I'm not encountering bone. I'm encountering scar tissue. Right, Sean? And the scar tissue, like I said,
He's feeling that.
yeah, it's all right, is soft. Sean? Oh, AP? Where do you feel that?
Where are you feeling that, huh? Right where you're working.
Not down your leg.
No.
That's actually great. If we're close to the disc, that's perfect. Yeah, that's really good. All right. I'm happy with that positioning of that second needle. You can see the first needle we placed at 5-1 is in the midline. It's perfect. Doesn't get any better. So, where did you have your last surgery? Orlando Health. I won't ask you who did it. Shot. I'm waiting for a shot. We've had a lot of patients from Orlando come here for us to fix them. Nobody in Orlando does this stuff. They can work at the Mayo Clinic, they can work at Cleveland Clinic, they can work at Texas Back, they can work at Kaiser Permanente, doesn't matter. They don't have the knowledge and skill of the treatments that we have here at Deuk Spine. They're all kind of stuck in a rut, you know, doing the same old thing, you know. We're building a stealth bomber, shot, and they're still building prop planes to fight wars. Shot, I'm giving you a little more numbing medicine, okay? Shot. That should help you a little bit. Let me know if that's better. Can you tell if it's better?
How's it feeling? Yeah, it's okay.
All right. Shot. Where was that?
Is that down your leg or in your back? Back.
Shot. 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 Give me an AP. We're almost done, okay? How long have you had back pain for? 2.5 years. So before 2.5 years, you never had back pain. What happened?
He plays golf.
Just kind of came on?
He just plays golf, he says.
It just came on? Uh-huh. Did you ever get into an accident? All right. Well, you can see the needle is, first of all, he has congenital stenosis, for those of you watching the x-rays. Very short pedicles. You can see how long the vertebral body is. There's virtually no space in the spinal canal. But that has no bearing on the actual cause of his back pain. How much of your pain is back versus leg? 80? 80% back pain? 20% your right leg. Let's get the light situation. All right. Well, I got good news for you. You're through the hardest part, in my opinion, my hardest part, which is getting down to the disc safely. We got all 3 disc access, so you're doing great. We're almost done. The first disc is the L5-S1. That's the lowest one. He's got another bad disc damaged at L4-5. And then we got a third disc, L3-4. Now, based on where he showed me his pain is during clinic, he pointed to these areas and said, that's where my pain is. And so looking at his MRI, I figured out that his pain is actually coming from 3 discs, because the MRI shows 3 bad discs, 3 damaged discs, herniated, bulging, annular tear, degenerated, whatever you want to call it. Are you comfy? I know you know what happens next because we talked about this. Am I right? All right, just hang in there. How bad is that on a scale of 1 to 10? Give me a number. 9 is the highest it went? 10? Is that where you typically get your back pain? All right, so show them, Jordan, show the audience the actual tear in the back of the disc. Yeah, that's the herniation, but go in a little bit right there. Now go in a little further. Where does the tear start? It starts right there. Go a little more left, right there. That's the inside of the annulus, and show them the outside of the annulus. There, a little more further, right there. So that whole black line there is a tear running through the annulus in the back of the disc called the annular tear. It's called the posterior because it's in the back of the disc, annular tear. Show them the annular tear in the front. See the annular tear in the front of the disc there? That doesn't cause pain. It causes no symptoms whatsoever. We never fix it, and yet we always cure people's back pain. We cure the back pain that comes from the disc. Only back pain that comes from the disc. That's all we're doing today. We can't cure back pain that comes from a fracture with this procedure. We can't cure back pain that comes from facet joints with this procedure or piriformis muscles. So L3-4 was 10 out of 10 at its worst, concordant, meaning the kind of pain he gets every day. You better? Is that pain gone? Was the pain gone?
Not quite.
Oh, okay. So you have a little bit left?
Yeah.
How bad is it right now? Huh?
How bad is the pain, 0 to 10?
Right now. Just right now.
6.
All right. Shot? How bad was that? What's the highest that went?
10.
Is that where you get back pain every day? All right, so we had another 10 out of 10 disc, and that's at L4-5, and that is concordant, meaning that's where he gets back pain every day. All right, my friend, we're going to put you to sleep in just a minute. I'm almost done.
Got one more to go.
Don't pre-warn people. I know you're just trying to help. You better?
A little better.
How bad is that on a scale of 1 to 10? All right. Is that where you get back pain every day? Okay, 10 out of 10 again. So you get to go to sleep now. What languages can you speak in? All right, then you're going to count from 1 to 100 out loud in English. Can you do that for me? 1 to 100 out loud. You can't cheat. You got to go 1, 2, 3, nice and loud so we can hear you. Keep going. Okay, great. So for those of you watching, and of course my patient who's going to watch this tomorrow when he gets a copy of this, we record and broadcast all of our surgeries so the world can watch what we do. We have nothing to hide. Do we ever have complications? You know, very rarely, fortunately. But if there is one, you're going to see how we deal with it. So this is endoscopic spine surgery, and it's in the lumbar spine or lower back. It's transforaminal because we go through the foramen on the side. And literally we're entering the spine not by removing ligaments and bones and discs and all kinds of important things that you want to keep. We're going through a hole that's already there. And we actually enter the spine right where the herniation starts. So we're going to enter into the disc and push the herniation back in the disc. So we're going to start with the bottom disc, L5-S1. Shot. Now our patient is asleep. You can see the guide wire at the front of the L5-S1 disc. You want to show them the guide wire there, Jordan? At the, what? Oh, hey, Monica. Show them the guide wire at the front of the disc, 5-1. Right there in the disc. There you go. See the white arrow? Flynn, you see that white arrow there? That's
Yes,
the
we do,
front of the
doctor.
guide wire. All right, now we've got a guide wire. We're going to take this dilator. Can you see this dilator? And we're going to slide it down the guide wire. It's going to pass from the skin incision all the way down to L5-S1. Why don't you show our audience, Flynn, the video showing why herniated discs do cause lower back pain. What's the mechanism? Do you have that video loaded up?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. We were just talking about the manufacture of these tubes and devices. They're out of Germany. They're all FDA approved. Everything we do is FDA approved here at Deuk Spine. And we were just talking about how they develop this stuff, and as usual, I don't have much love for the company, but I do love the product. Oh, Luis Manley. You're gonna get a break after next week, right? With me being out of town. So folks, if you've got questions, feel free to ask them. We'll be happy to answer your questions. Sean? Right now I'm putting the tube in, and a lot of people freak out when they see me hammering this thing. But the reality is that in orthopedics and in neurosurgery spine, we hammer things and chisel things and hatchet things and drill things all the time. It's standard. As a matter of fact, what I'm doing with this hammer is pretty mild compared to other types of surgery where we use drills and saws and other kinds of hammers. Shot? All right, beautiful. We are ready to do our first disc. Our first Deuk laser disc repair at L5-S1. Now, the Deuk laser disc repair surgery has been peer-reviewed and published multiple times, both in journals, peer-reviewed journals, scientific journals, as well as in books. We have our procedure published in a book published in 2022, as a matter of fact, on endoscopic spine surgery. And I just gave a invited talk in Los Angeles at the World Congress for Brain Mapping and Therapeutics on cervical and thoracic endoscopic surgery. Okay? All right, we are inside the L5-S1 disc. Our patient is local. This patient is local. He's from Orlando, Florida, which is about a 40-minute drive from where we are. And our patient before was from Philadelphia. Let me have the grabber again. And our first patient for the day was actually a local gal. She was a nurse, local, right? She had the sacroiliac joint fusion. Here you go. Any questions from the audience?
Yes, we do have a question from Joseph Fishing on YouTube.
Excellent.
Does disc desiccation or herniated disc cause more feelings of stiffness?
Great question. Does disc desiccation or stiffness, herniation or degeneration cause more feelings of stiffness? I think the answer is yes. I think they do, but I think it's gradual. I think it happens slowly over time. It's not like you suddenly feel it. And the reality is we know the amount of movement normally found at these discs, both in flexion, extension, and lateral bending, rotation. And it's really not a lot. It's around 4 degrees on average of movement with a normal disc in the lumbar spine. So there's not a whole lot of movement. And because there's not a whole lot of movement normally at the disc, there's not a whole lot of movement to lose when you lose that disc, when it gets degenerated. As a matter of fact, I've been doing spinal fusions now 26 years, and I've done thousands of spinal fusions, and I've never had a patient complain about loss of movement with a spinal fusion. Isn't that odd? You'd think that people would complain more about losing movement with spinal fusions, but they don't. As a matter of fact, a lot of people move better after a spinal fusion. Why? Because their pain is gone. The painful disc that was hurting them so much is no longer there. It's not moving anymore. Stand by. So, because their pain isn't there anymore, they actually move better. But you're correct. Once you have a degenerated disc or fused disc, you are going to lose the movement there for sure. Oh, come on. You're kidding me. So this is all part of the herniation here. You can see the golden color. It's totally abnormal. This is not calcified, but collagenized disc herniation. So the hernia has become scarred. You see, the disc is quite interesting. It only has 2 normal components. It has the annulus fibrosus, which is a white wall, and this is not normal annulus. And then it has the jelly in the middle, which this is definitely not normal jelly. So what we're seeing here is degenerated nuclear material. It stains blue. And then that yellow blob at 12 o'clock, that's actually scar tissue. The pink stuff is the end plate of S1. This here is part of the annular tear. So I'm removing part of the herniation here that's kind of scarred down to the annulus. Goodbye. Good riddance. Oh, it does not want to come out. Oh, it's the one thing that's annoying is I want this stuff to float out, but it just gets stuck sometimes, and then you gotta stop with the laser and go in and use a grabber. All right, great questions so far from our audience today. Any more questions?
Yes, we have one more question from Mike Saunders on YouTube, and he's asking, what are patient's symptoms?
This patient's symptoms we talked about just a minute ago, Mike, but thanks for asking. This patient said he had 80% back pain, 20% right leg pain. So his pain would go down the right leg, like what we call sciatica, and he'd had some weakness in the right leg and numbness. Weakness, numbness, tingling. but 80% was back pain right where his herniated discs were. I kind of mapped it out. And then we just did that discogram a minute ago. We just proved that the back pain is definitely coming from those herniated discs. The number 3, 4, 4, 5, and 5, 1. We're actually fixing the 5, 1 right now as we speak. We're going to move on to the other two in just a minute. All right, this is the top of that annular tear, the most posterior part. And I'm going to bring the laser in, and we're going to go ahead and clean this up. None of this is normal here. This is all a result of the tear in the back of the disc and chronic inflammation. If you're not sure what chronic inflammation is, think about the last time you had a piece of wood, like a little wood splinter stuck in your finger. And just think about how tender it was, how red it was, how swollen it was. It was painful, red, tender, and swollen. That's what inflammation is. Inflammation is your body's efforts to get rid of what it thinks is a foreign body. Foreign body means something that shouldn't be there. So a splinter is a foreign body. It's actually a piece of wood, right? It doesn't belong in your body, but it's there because you stuck your finger on a piece of wood and the splinter went inside. And then when your blood system starts seeing that splinter in there, it says, whoa, what are you doing here? You don't belong. And it attacks the splinter. And the way it attacks it is it makes the blood vessels very permeable, and it allows cells to come out of the blood vessel and go into the surrounding tissue around that splinter. And they just start attacking the splinter and trying to destroy it, basically. It's your body's attempt to destroy that foreign body. And the cells start releasing chemicals. Those chemicals try to dissolve, basically, break up the splinter. That's a piece of herniation right there. So the thing about the disc herniation is your body thinks the jelly here from the center of your disc is actually like that splinter, a foreign body. It's not supposed to be there. Because I'll tell you, this stuff down here, the blue stuff, has never been seen by your body before. You see, your ability to recognize yourself comes from substances and cells that are located in your bloodstream. We call it humoral mediated. Not like humor as in funny, but humoral as in, through the blood system. And kind of like a security system, right? It recognizes everything that's part of you because it's memorized it since you were just an embryo, a fetus, developing. So it knows what should be there and what shouldn't be there. And it basically recognizes everything that should be there and says anything that it doesn't recognize shouldn't be there. It must be foreign. And it tries to get rid of it. So what happens is your inflammatory system doesn't recognize the blue stuff, the jelly, because it's never seen it before. Because it's been stuck in the center of your disc, hidden away in a vault your whole life until you tear your disc and you squeeze that jelly out to where the blood system or humoral system can actually see it. Right? And once it sees it, it instantly attacks it. Okay? So, if you've ever watched the Korean movie Parasite, I think it won like an Emmy or something. There was a guy living inside a house for 30 years, and the family had no idea he was inside the house under the stairs, living in a secret room. That's what this nuclear material is. It's been living in the house for their whole life, except your security system didn't know it was there because it never saw it before. So as soon as he came out, it attacked him. And of course, that's not what happened in the movie exactly, but you get the idea. And that attacking is incessant, 24 hours a day, 7 days a week, right? is kind of like Amazon. You can order things from Amazon 24 hours a day, 7 days a week. It never shuts down online. And that's exactly what your inflammatory system does, is it attacks 24/7, even when you're asleep, and just destroys the discs over time. So what I do is I come in and I remove that jelly that's sticking out where it's not supposed to be using a laser. We call that the annular debridement. And by doing that, the jelly now disappears and your inflammatory system thinks it's gone, and it shuts down the inflammatory process. So basically it calls the troops home and says, boys and girls, we're done with the war. Everyone can take it easy and go back on vacation. Yeah. So the Deuk laser disc repair really is just helping your body heal itself. It's not really putting anything unnatural in your body. There's no cages that go in, there's no screws, no bone graft, no cadaver bone. And because of that, a lot of companies don't want you to know about this, because they're not going to make money off of it. There's nothing for them to stick in your body and make money off of. Okay? But that's exactly why it's a good procedure for you. Because you don't want something in your body you don't need. And that's why we do these broadcasts, so people can learn the truth. All right, let's show everybody the video of the Deuk laser disc repair, how it works. Can you do that for me, Flynn?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
We are just wrapping up L5-S1 here. I've taken all the herniation out. I'm going to see if I can show you the nerve root. It's actually up there in that blue stuff, so it's kind of hard to see, but it's there. You can kind of see the edge of the dura there, but it's also buried in fat, so I'm going to leave it alone. All right, but we took care of the source of pain, and we're done with 5-1. We're going to move on to the next one. If you want to show everybody here, Flynn, the endoscope. Can you see the endoscope, Flynn?
Yes, doctor.
Yeah, right here. So, pretty cool little thing. Now, chances are your spine surgeon doesn't do the surgery. It's too advanced for them. They've never done it. They probably haven't ever seen it. Unfortunately, like I said, just like the nuclear material is hidden from the vascular system, normally endoscopic surgery is hidden from spine surgeons, because the companies that make those screws and rods don't want them to know about it, and they don't want patients to know about it either. All right, one down, 2 more to go. Bring in the fluoro. And we still have 2 pedals for the laser, right? We have one good one that's still sitting in the box. And this one's been doing a great job. Go ahead there, Monica. Oh, you know what we need to do, Luis? I think you need to get that thing around my wrist, and we need to put the blue towel. Yeah, we had a lot of water on the floor.
And
Go, go, go.
Sacha, can I have a ball from back there? You know, a stir ball, please.
Watch your arm. Yeah, I think. All right, let's get the guide wire. We're going to be at 4-5 next. Where is the picture? Guys, we need a shot. We need the image up there. Yeah. So it's too zoomed in. Any way we can zoom out a little? Shot. That's better. Like I said, we're going for 4-5 next. Still a bit blurry. Shot. Yeah, that's good. Dilator. Okay, coming in. Oh, there's something in there. You have another guide wire? Can you guys see this, Flynn, right here? Oh.
Yes, doctor.
Right here, the incision?
Yes, we can.
Good. All right, so we're going to come down on L4-5 now with the dilator on the right transforaminal approach. The dilator spreads the muscle, doesn't damage it. Patient may be a little sore for a day or two from the muscle, but in general, the muscle heals very quickly from this procedure, especially when compared to open spine surgery, where it takes a lot longer. And the muscles are typically permanently damaged with open spine surgery, like laminectomy. Shot. I gotta see that 4-5 disc a little better. Monica, hold on. That's my roll. Shot. I think it's a WAG issue, but I'm not sure. Give me that. Huh? Shot. 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 All right. So at this point, we're attacking L4-5. You can see the tube and the foramen coming down. He's relaxed, correct? Let's pull back the dilator a smidgen. Yeah, see if you can. Just a little bit. Shot. That's perfect. Keep it there. Yeah. Shot. All right, we're golden. Let's get that dilator out and we're ready to go. So we're inside the L4-5 disc at this point with the tube. We're going to work inside the disc and clean it up, get rid of the arthritis. It's called an annular debridement. The annular debridement's really done with the laser. Yep. I'll do that. Just give me the blue towel. Thank you. Alrighty then. It's been a long day. This is we have 2 discs left to repair, this one and the next one above. We know they're both painful because we tested them with the discogram. And all 3 discs were 10 out of 10. 10, that means a patient, when I injected dye, they felt pain that was so severe, they rated it as a 10 out of 10. That's the worst pain. So I feel really good that these are his pain source, and we're going to fix these right now. So by the time he's done, he'll get out of surgery, and I think his back pain will be gone. And remember, not everybody's back pain comes from a herniated disc. That's just the most common cause of back pain. Some people have pain that comes from facet joints, piriformis muscle, and other sources. I need that pedal right there, please. Yeah, perfect. Nice job. Thank you. So what I try to do for everybody is figure out ahead of time where their pain's coming from in the clinic. And, you know, we try to do it virtually. You know, if somebody's coming from out of town, we'll do it virtually, but I have to confirm it when they actually get here and make sure that that's correct. We get surprised sometimes. Some patients have more than one source of pain. Actually, most patients have more than one source of pain. Some patients have things that we didn't pick up on, though. Alrighty. That's all right. We're good. You all right? A lot of blue dye. What is it? Uh-huh. There's the tear right there. You see it? All right. So, Flynn, what videos? We've shown them how a herniated disc in the lower back can cause back pain. We've shown them what the Deuk laser disc repair does to fix damaged discs, right?
Yes, doctor. We can show them the lumbar comparison video.
Yeah, let's show them a video that shows a difference between, you know, what other surgeons might do to fix back pain versus what we do. That's a fusion. A lot of fusion surgery for years and years and years. As a matter of fact, I even published peer-reviewed publications on how to do fusion surgery well, the proper way to get rid of back pain and leg pain and correct deformity. If you look up in PubMed, you'll see one of my publications. Lumbar fusion. But I've really don't do a lot of fusions anymore because we found that no matter how degenerated the disc is, no matter how collapsed the disc is, we get almost every single time. And I've never had a disc that I couldn't fix endoscopically. Like, I may not, if I can't reach it, that's one thing. I have to abort it. But I mean, once I've gone in and repaired it, I've never had a disc where the pain didn't go away. That's the pain from the disc I'm talking about. Like I said, some people have pain from other areas like facets or SI or piriformis, and we're not treating that with the surgery. So they may have that pain after surgery or before surgery. But as far as disc pain, the disc pain always goes away with the surgery. The only way it comes back is if the patient re-injures the disc. All right, there's the tear, the annular tear. You can see it pretty clearly. There's a piece of herniation.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
Get this to your arm. Got it back.
That's amazing. All right, we are done with this disc. And we're coming out, and we got one more to go.
We have another question, doctor.
Okay. Standby laser.
Lights on, please.
It's a question from Mike from YouTube. Is the ruptured disc pushing on the nerve roots, spinal cord, or both? Or is just the inflammation from the rupture causing the pain, numbness, and weakness?
Oh, great question. I love it. Very insightful question. Thank you for asking. Mike from Facebook. Is that what you said, Flynn?
Mike from YouTube.
Mike from YouTube? Yeah, so you're right. The inflammation in the back of the disc is getting on the nerve and causing pain to go down the leg. And then also the inflammation in the back of the disc is causing the back pain. The back pain has nothing to do with the nerve root. Okay, nerve roots, when they get inflamed or they get pressed on, don't cause back pain. Back pain only comes from the disc. Nothing to do with the nerve root. Come on in, you can come in. I'm waiting for you. So, the leg pain is due to inflammation of the nerve root from the disc, and the back pain is just due to inflammation of the disc. And it has to be the back of the disc. In other words, the tear in the front of the disc won't cause pain. Now this patient also had compression of his nerve roots by the disc herniation. And that compression can cause weakness, numbness, reflex changes, and tingling. But his main complaints were back pain and leg pain. And yes, we found weakness on his exam and numbness on his exam. But those really weren't even things he complained about.
We need over there, Rita. The X-ray is back there. Yeah.
So, as far as what the patient wanted to get rid of, it was definitely the back pain, definitely the leg pain, which is all inflammatory. Sean? Not compressive. Great question. Very insightful. I'm glad you're paying attention. Sounds like you are. I always preach about how important inflammation is in this whole thing. Inflammation accounts for 95% of people's symptoms from a herniated disc. It has nothing to do with pinching. which is why most surgeons miss it, because all they're looking for is pinching. Pinche, right, Luis?
Yeah.
Pinche. What we call pinche. And if all you look for is pinching, then you're a pinche cabrón. If you couldn't tell, I grew up in California. You like that? It's so sad, though, seriously, how dogmatic doctors are about herniated disc has to be big enough to push on the nerve root for us to treat it. No. That's the whole point. You're missing 95% of the disease that you can fix as a surgeon. Because only a surgeon can do what I'm doing. Who else hammers stakes into people's spines? All right?
Yeah.
Give me a second, I'm not done. Shot. Pull the guide wire. All right, yeah, we are inside the L3-4 disc. You could actually see the bulge if you go back and rewind. And that bulge was the herniation. Small herniations are called bulges because they literally look like a bulge. And bigger herniations are called herniations. I don't know why. It's kind of, in my opinion, stupid, but they're all herniations. Yeah. It all starts with an annular tear and then a herniation of the jelly through the tear. All right, let's get the flow out. So we are inside the L3-4 disc. This is the last one we're going to fix today. This disc was causing 10 out of 10 pain for the patient. We tested it. We've lost maybe 1 cc of blood the whole surgery. Can you imagine doing spine surgery, fixing 3 discs, and only losing 20 drops of blood? Okay, that's why the surgery is so amazing. There's no hospital stay. There's no pain medication needed except for a muscle relaxer and an anti-inflammatory for 1 night. We don't give any narcotics. Nobody gets drugged up after the surgery. You know, if you had surgery elsewhere, you'd be in the hospital for a day or 2, maybe even a week, and then you would be on powerful drugs. Look at that tear right there. That is beautiful. Can you all appreciate that? I'm going to move it a little bit. That is, see how the edges move opposite of each other? That is the annular tear. That is what I discovered is the source of back pain. Has nothing to do with the nerve root. I published it 10 years ago. And we do what's called an annular debridement with the laser. We're the only facility in the world that does this in 2022. Even though I've been teaching people how to do it for years, they don't do it. They just ignore it. They go out and do fusions. Now, granted, it takes time to learn the technique. I give you that. It takes about a year. And then you have to be taught by an expert like me. And then you also have to buy all the equipment and set up a center to do it. So it's a big investment financially. It's a big time investment. But it's worth it for the patients who really don't want fusions. I think someday fusions will literally disappear. There'll be a few done every year, probably less than 2% of what we see today. The other 98% of patients who get fusions will end up getting this procedure, the Deuk laser disc repair.
We have a question, doctor.
Sure.
Trevor from YouTube is asking what type of disc injuries would require fusion only as opposed to the laser repair?
What type of disc injuries would require fusion only as opposed to the Deuk laser disc repair? There are none. But if somebody has a complex fracture, so it really isn't a disc injury, it's more of a bone injury like a fractured vertebral body, fracture dislocation, then you're going to need a fusion. So that's really trauma. I think most fusions today are done for what are called degenerative disc disease, or degenerative spine conditions. You can also do fusions for tumors of the spine, infections, if they create instability. And you can do it for trauma. And really, degenerative disc disease is trauma. It's the same spectrum of disease. Trauma is what causes the annular tear, which then leads to the herniation with activity. And it's trauma that is the source of all disc injuries. The trauma is, of course, the tearing of the annulus with something that happens, car accident, slip and fall. You know, just watch Fail Army on YouTube and you'll see what kind of trauma I'm talking about. And so people have trauma to their spines and they may not have any symptoms right away because all they did was tear the back of the disc, but you got to have the jelly push out too. So maybe when they had that trauma, they just tore the back of the disc. They made a tear, but the jelly hasn't leaked out yet. And so when the jelly starts coming out, you know, with lifting, bending, twisting activities that push down on the discs, then you get the jelly squeezed out. And once the jelly squeezes out, then you start getting inflammation. Now, if you could heal your tear before the jelly squeezes out, before the herniation occurs, then maybe you have a chance of not having symptoms. But most people end up being active right away and their tear doesn't heal quick enough and they end up herniating. So they get the pain. But to answer your question, you know, this surgery is appropriate for disc injuries. And they start with annular tear, bulging disc, herniated disc, slip disc, ruptured disc, extruded disc, degenerated disc. So those are probably 95% of spine surgery today is for those conditions. And probably 90% of fusions are for those conditions. So I think we're going to get rid of all the fusions for the disc conditions. There really is no need for fusion for any disc condition that I can think of. You could do the laser surgery instead. I've done the laser surgery now for herniated discs associated with scoliosis, spondylolisthesis, facet arthropathy, stenosis, kyphosis, lateral listhesis, all of those conditions associated with a disc problem, and we're operating on the disc and the disc only, and we're able to get rid of the pain. So I really think it's just a matter of time and awareness before all those fusions go away, which is a good thing, trust me. Spine surgeons need to be accountable to their patients, not to themselves.
We have another question, doctor.
Yeah.
Another question from Joseph Fishing on YouTube. When was the last time you did brain surgery?
When was the last time I did brain surgery? Great question. It's been a long time, years. But I could tell you though, it's like riding a bicycle. You don't forget. We did so much brain surgery in my many years, 7 years of training, and then of course afterwards for years, that I could do brain surgery tomorrow perfectly if I had the right equipment. Now, you know, I will say with brain surgery, it gets a bit more complicated because, you know, there's so many types of brain surgery. There's tumor brain surgery, there's aneurysm brain surgery, there's vascular malformations and hydrocephalus, and the list goes on and on. There's pediatric versus adult, there's trauma, so skull base. So basically what I'm saying is I would not attempt to do all types of brain surgery because a lot of brain surgery requires very specialized training and expertise, just like my spine surgeries do. And so I don't even operate on patients with aneurysms because I just tell them, look, I haven't done aneurysm surgery in many years and I am not the best surgeon for you. I would recommend you go to University of Florida in Gainesville or, one of the top universities where the top aneurysm surgeons are. So brain tumors, most brain tumors, as long as they're not skull-based, are pretty easy to take out safely. I can take them out pretty easily. I have the equipment, the training, the expertise. I can manage those patients quite well. So it's been a long time since I've done a brain tumor or brain surgery, but like I said, it's not something you forget when you're well trained as a neurosurgeon, like I am. I was fortunate enough to go to what I truly believe was the top neurosurgery program in the country when I did my training at University of Florida in Gainesville. And that's because I had a really good mentor, Dr. Weiss, who happened to be the chairman of all the residency review committee for the United States. And he knew every neurosurgery residency backward and forward. He knew the residencies better than the chairmans of each residency did, because it was his job to. It was his job to make sure the quality of education happening at those centers was equal to the standard that was set by the American Board of Neurological Surgery. He was the chairman of the residency review committee, and he was my mentor at USC in Los Angeles. So he told me the University of Florida was the best neurosurgery training program at the time, and I believe him, and I went there. So I feel, even though I haven't operated on a brain in a while, I could if I needed to, in a pinch. Doesn't mean I'll be going out tomorrow and doing brain surgery. I always try to refer patients to somebody more qualified than me if it comes to a condition I don't treat regularly. Bring it to 12 o'clock, Luis. 12 o'clock. What do you got to do with that wire? Bring it to me? Yeah, whatever you do, I don't know. I think it seems to be okay. Great question. I haven't been asked that question in a long time. I've had people ask me if I do brain surgery still. I say yes. Because I do, if it comes up when I'm on call.
There's another question from Mike again on from YouTube. If the foramen is tight and compressing the nerve with bone spurs or disc replacement, is it difficult to reach and open the foramen?
Oh, that was a loaded question. Can you repeat it?
If the foramen is tight and compressing the nerve with bone spurs or disc replacement, is it difficult to reach and open the foramen?
No, we're in the foramen, Mike. This surgery, we are in the foramen. This is the foramen. We're passed through the foramen. It's difficult for any other surgeon to get to the foramen because they have to remove bones and ligaments to get there. But for me, I'm actually inside the foramen, so it's really easy. That's how we got into the spine today, through the foramen. I need 3 minutes. This is just about it right here. You can see that blood there is actually the veins. He's not liking this too much. That's all right. Can feel him. His leg is tightening up. It's a reflex, by the way. We're just activating a reflex pathway with the laser. It's not the laser hitting the nerve or anything, it's the pressure wave. All right, we're pretty much done. The nerve root's going to be up there. Let me see if I can just do a little bit more here. How's he doing? Another question?
There's a question from Jacob on YouTube. Do you do SI joint fusions?
Hey, Jacob. Sorry. Do I do SI joint fusions? The answer is yes. As a matter of fact, we just did one today. If you go back and rewind on YouTube, you'll see us doing one. It would be 2 videos before this one. We did it this morning. We did a right SI joint fusion. Sorry for the poor visibility, but there's a little bit of bleeding from the end plate. Not much I can do about it. Fortunately, I know my way around the foramen. But we are in the foramen right now. Somebody asked about it earlier. Let me see if I can show it to you. We're actually inside that foramen. Okay? So, this is the foramen we're in. We're looking at the fat at 12 o'clock. I want to do a little more right there, Luis. That fat we looked at was epidural fat. Is he all right? All right, we're done.
Lights on, please. Thank you.
Scope off. Irrigation. Let's pull the pedal, please. Clean it up. Let's dry it off. All right, we're putting a little antiseptic in. Again, never had an infection in 16 years of doing this procedure. It's an amazing procedure. We're done. I'm going to show you all. We did 3 discs through this one tube right here. You guys see this tube?
Yes, we do, doctor.
You see the tube? All right. And everything was done with the endoscope. This is the endoscope. Can you see this, Flynn? We have
Yes,
an
we can.
attachment for irrigation. We have a light source right here, the blue cable. And we've got a camera right here. You're all done. Everything's going good. Got it? I'll hold pressure for a minute. All right. Any more questions? Type them up. I'll come answer them for you face to face. Everything went really well. We did 1 incision. You guys want to see this? It's about 8 millimeters. I went big today. And we just basically planted 3 needles in the 3 discs that we're going to fix. We did a discogram to see, are these discs really painful for this? Are they the source of his pain? Confirmed that they were. 10 out of 10 each one of them. And then I went in with a guide wire in 3 trajectories, and I went in and basically repaired 3 discs using the laser. Whenever you're ready. Oh yeah, you got to use the one with the teeth, because otherwise those crush the skin. You're picking the skin up, right? Yeah. So you want ones with teeth. Those are for, you know, we really shouldn't even have those. Is that all you have though?
Yeah, I guess that's some probably.
You know, you can use, but just don't squeeze the skin hard. But going forward, change them out, all right?
Yes, sir. Yeah.
All right, there it is. Beautiful. Nice job, everybody. Thank you so much for sticking around. I'm going to go answer questions. Our last patient's gone, right? Should be gone, the cervical. 4-level cervical. Yeah, when I checked on him, he was doing great. I think he went home. 16 years of doing this, we've never had to admit a patient to the hospital. I'm going to call our EBL 5 mil. No complications. This was a right approach, correct? L3-4. Perfect. Thank you for a nice day. All right, let me come answer your questions. Type them up, folks. Why don't you go ahead and run a testimonial for them? Dr. Deuk here at Deuk Spine Institute. It's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
Severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy, 2 spinal injections, massage therapy.
And how did you know those treatments did not work for you?
I had no relief at all. My sleeping continued to get worse, and my pain was never better.
And do you have relief now?
Absolutely. I would say I have 95% relief.
Awesome.
And it's amazing. After surgery yesterday, I put on a back brace. I walked out of here. I sat down yesterday for probably over an hour and had lunch. Last night, in bed, I had 0 pain. It's a miracle.
Well, we're very happy that you're doing so well. And your surgery was a great one because we fixed 2 discs. You had herniated disc at L4-5, L5-S1, and you can see in this footage right here that we grabbed the herniation out, and it was one of the herniations was really big, and it was really gratifying to get it off because it was resting on your sciatic nerve. Once we took it out, I think your sciatic nerve probably felt a sigh of relief.
Yes, absolutely.
Yeah, and the surgery went very well. The laser debridement of the annulus went well, and I feel like your pain's going to be gone. It's not going to come back.
I would agree.
All right, very good. Well, is there anything else you want to tell your viewers?
Folks, if you're suffering and you're not getting relief from those non-invasive therapies, then come see Dr. Deuk and have him look at your MRI and give a good diagnosis. And if you need to have surgery, you come down here. He will take good care of you, and so will his team.
I really appreciate that. Thank you so much.
Thank you.
I'm Dr. Deuk. It's January 26, 2022, and I'm here with one of my patients who you underwent the Deuk laser disc repair on your lower back for some herniated discs about a week ago.
Yes.
How are you feeling today?
Unbelievable. For almost 3 years, I had lower back pain, and it just, it just nags at you, wears you out. And then I came here, and you were the first one. I went to 2 other surgeons, and neither one of them picked up what was wrong with me, even though I had the MRI. And you came in, and you told me exactly what was going on, and you performed the laser surgery, and I'm like a different person.
Yeah.
A week later.
Yeah, you were a different person the next day, right? The day after, you had no pain, remember?
No, absolutely.
Yeah, so that pain's gone for the rest of your life. How does that make you feel?
New life.
Good. And, a long time ago, remember when people did something great, you say, what are you going to do now? They say, I'm going to Disneyland. You already went, I can see.
No, my wife's a big Disneyland fan.
Good for you. All right, so sounds like we helped you with your back pain, and it sounds like you're very satisfied.
Oh yeah, I'm recommending a friend of mine in Connecticut to come here. You have to come here. If you go anywhere else, I really think you're going to be wasting your time. So this guy just looks at you and he can tell what needs to be done. He's a fantastic talent, and I'm very grateful that I came here.
Well, we're grateful you did too, because it's going to change your life for the better. Congratulations.
Thank you, Doc.
You're welcome. Good morning, I'm Dr. Deuk Major. I'm here with one of my patients, and you traveled to Deuk Spine Institute here in Florida from where?
New York, Poughkeepsie, New York.
Awesome. And why did you come from New York to Deuk Spine here in Florida?
Because I heard that this was the best place for me to go.
What kind of problems were you having that you needed to come here?
I had lower back problems and numbness in my leg, which was my left leg. This was the best place for me to come.
Okay. So you had back pain, sciatica down your left leg, pain shooting down the left leg.
Yes.
And that was just yesterday, right? When you
yes,
had
that's
that.
correct. Yeah.
And what, do you still have your back pain today?
No more back pain.
It's gone.
Go on.